I'm delighted to be able to speak to you today and to share thoughts on the overarching challenge of the burden of cancer. And I've also decided that I thought it would be helpful to also cover a focus on radiotherapy treatment as well, because that's a particular area of research interest of mine and not covered in the additional talks that are planned in this really exciting seminar series. And so I'm going to talk about the multidimensional nature of cancer. And what I'm going to cover in the talk this afternoon is, firstly, the scale of the global challenge that we're facing with cancer, how health inequalities actually impact cancer outcomes, and also some views on the fact that we need to understand more about that. A very brief amount about cancer research in Leeds, and then a focus on radiotherapy research and clinical trials. So cancer is one of the world's biggest challenges, and it accounts for the second most common cause of death globally. And whilst we have 23.6 million new cases diagnosed in 2019, that's projected to rise substantially to 28.4 million by 2040. We still have a very major challenge where nearly half the patients are not surviving at 10 years, and therefore there is a very major need for us to make substantial progress in improving cancer outcomes. There's also a major burden associated with the impact of cancer, measured through disability adjusted life years, as 250 million in 2019 over the past decade. And that includes premature loss of life, but also the disability associated with the side effects of cancer treatment. So there is a very major piece of work to be done. And although I'm not going into it in particular detail today, we know that the COVID pandemic is actually going to create an even greater challenge, which of course we'd be happy to discuss. So cancer is the first or second leading cause of death before the age of 70 in 60% of countries across the globe. And if we look at the UK data, as I've mentioned, although survival's doubled over the last 4 decades, we're still in a position that 50% of patients are surviving 10 years or more from their cancer. And there is also a huge variation in the survival between individual cancer types, indicating there are certain cancers where we really do need to make very major progress and where there are very major challenges. That also relates in part to the actual challenges of health inequalities. So you can see here the 5-year survival by cancer type across England published last year, with outstanding outcomes for testicular cancer. And it's a real triumph. That's one of the disease areas that's been cured with chemotherapy alone. Many cancers need multimodality therapy. That includes radiotherapy, surgery, and chemotherapy. You can see that breast cancer is one of the commonest cancers, has overall a survival of 5 years of greater than 80%. And at the other end of the spectrum, what Cancer Research UK tend to call cancers of unmet need, lung, esophageal, liver, brain, pancreas cancers, and mesothelioma, all have cancer survivals of 25% or less, and therefore indicate there's a real need to make major progress in those cancers. Thinking about the UK perspective, every 2 minutes, someone in the UK is diagnosed with cancer, which is quite a concerning statistic. And 1 in 2 of us will be diagnosed with cancer in our lifetime. Now, many of those will be cured, and those who are at risk, we are very much wanting to change the dial and reduce the risk and prevent cancers from happening in the first place, but also enabling better treatment. 375,000 new cases diagnosed per year in the UK. And the estimates are that up to 38% of cancers are preventable. And that's an area of relatively limited investment in cancer research historically, but that is changing. And many funders are actually putting more emphasis on investment in the screening, early detection, and prevention of cancer. So, having set the scene, let's talk about health inequalities. And you can see the actual index of multiple deprivation across England here, and how the north of England has many parts of the region that are associated with neighborhoods with the worst level of deprivation, shown in the dark purple. And the north of England is a particular area where this is a very major problem. And then if we narrow the lens down and look at Yorkshire, we have currently the third worst regional cancer outcomes. And in the areas of greatest deprivation, which is around 25% of the West and South Yorkshire population, mortality is 53% higher in the most deprived communities compared with the least. So this is the distribution of stage at diagnosis according to the deprivation quintile. And you can see that one of the reasons for these poor outcomes is that in the most deprived communities, patients are presenting with more advanced cancer. Particularly noticeable that the earliest stage of disease is significantly lower and significantly higher for the later stage of disease in terms of stage 4. When we look at individual cancers, now this is relatively old data, and I'll show you a new piece of data to follow. And this is comparing the 5-year survival according to the area of deprivation. And you can see that there is a significant survival detriment, worse outcomes, for a range of common cancers in patients who live in the most deprived communities. This is data that was published about 4 months ago now from the National Cancer Prostate Audit. And this is actually looking at the percentage of patients who present at the time of their diagnosis with stage 4 or metastatic disease, according to cancer alliances in the NHS in England. And you can see quite a striking difference between particularly the northwest and the south of England, with substantially greater percentage of patients presenting at the time of their diagnosis with metastatic disease. Now, this is something that we need to understand in more detail, and there are likely to be multiple explanations for this, one of which may well be a late presentation or a later presentation from patients from the more deprived communities. It may be that they're less aware as to what the symptoms they have may actually mean and therefore present later. But we also need to understand cancer biology here, and we can't necessarily assume that actually that there may well be other factors at play. Multimorbidity is linked to social deprivation. Some of the biomarkers and some of the biological factors may also be contributing. And this is an area of really important research that needs to take place to make sure that we understand and actually therefore tackle this. The other side of the coin in prostate cancer is that screening for prostate cancer is not a standard approach, because there is not a refined enough method to actually demonstrate that routine screening for prostate cancer is the best option for patients. And that can actually also lead to early diagnosis of relatively indolent prostate cancer and overtreatment. So it's a complex situation which needs careful thinking and further research to really understand that in more detail. In the prostate cancer audit, there were 6 factors in a multivariate analysis. I'm showing one of these, which is the index of multiple deprivation. And you can see a 30% increase in the odds ratio for patients presenting with metastatic disease, which is highly statistically significant, according to the social background of the patients. So I'm going to briefly touch on cancer research in Leeds and to illustrate how we're approaching that. And of course, across the country and across the globe, cancer centres are tackling cancer research, and there are great opportunities for interdisciplinary research, particularly linking engineering, physical sciences, biological science, and clinical science. I think one of the key messages for me today is the opportunity is very clear for us to be able to work more collaboratively across disciplines, across the faculties that we work in, and particularly to break down the barriers that exist between engineering, physical, biological, and clinical science. Because by joining those up and developing a greater understanding about why treatments work and why they don't work, and how we best develop scientifically and rationally novel therapies, that will accelerate the progress that we make in cancer. So I thought you might be interested in this slightly complex timeline, and obviously with the recording, you could come back to look at this. But we have a rich cancer heritage in Leeds over a century or more. And these are just some of the interesting landmarks, starting from back in the early 1900s. So Barclay Moynihan, pioneer in colorectal surgery and colorectal cancer. And William Bragg, which I'll mention in a minute, about his discovery of a radiation beam behavior, the Bragg peak, but also in the discovery of X-ray crystallography. We had in Leeds a radium center in 1929, and we were treating over 1,000 patients per year in the 1930s with radium. And we had a major grant for a radioactive source, a cobalt source, which was considered too dangerous to be placed in the infirmary, which led to Cookridge Hospital being established near the airport and becoming the regional cancer center for radiotherapy. Craig Jordan was a pioneer, did his PhD in the Asbury Center around estrogen receptors, which led to the discovery of tamoxifen, which transformed the lives of patients with breast cancer across the world. And it was through the pioneering work in Leeds and Craig's industry partnerships with ICI that followed from his PhD that led to this discovery that transformed the lives of patients. We were very influential in the organization of cancer services and centralization of services across cancer centers to improve outcomes. Peter Selby was the first Leeds Professor of Medical Oncology. Sir Alex Markham was the Chief Executive of Cancer Research UK. We had the outstanding Leeds Cancer Centre founded in 2008, which is £250 million investment, and major investments in clinical trials, radiotherapy, and Leeds Cancer Research Centre. So Richard mentioned this in the introduction, and Leeds Cancer Research Centre has a greater than £125 million cancer portfolio. There were 9 case impact studies in the 2021 REF. And this centre is very much about interdisciplinary research excellence, joining physical, biological, and clinical science, linking with our NHS partner, Leeds Teaching Hospital Trust, one of the largest in the UK, tackling cancer inequalities, and having a world-leading track record in translating research into the clinic. And this is really how cancer centres can make a difference for cancer and also have an outstanding environment to train the cancer researchers of tomorrow. So our research strengths are represented in these pillars of understanding cancer's biology. And the whole approach to cancer in one slide is very much focusing on how we prevent and have early detection and diagnosis to reduce the number of patients actually being diagnosed with cancer, and also by detecting earlier at an early stage, getting a better outcome. How we can use intelligent technologies and link the technologies with AI and computational science and biology to really make progress beyond standard drug therapies. Approaches that use biomarkers to actually allow us to be more precise and stratified in our treatments. That can lead to smarter, kinder treatments. And as OncoEng is focusing on living with and beyond cancer and actually tackling significant problems and major symptom burdens that actually patients suffer as a consequence of their diagnosis. All of this research is underpinned by world-leading areas and established areas of disease strength in Leeds, and these are examples and not an exclusive list of our established disease areas of strength. And in all cancer centres, this is underpinned by strengths in world-leading infrastructure and capabilities. Now, I think one of the messages I want to really convey in this slide is these are some, but not all, of the key research strengths we have in Leeds. And these themselves have substantial grant funding and high research performance. But the progress that we'll make will be more effective and quicker by linking these disciplines together to actually allow us to get a greater understanding of cancer biology, how we develop novel therapies, how we translate them into the clinic, and how we measure real-world outcomes. And it's this connectivity across the disciplines and the faculties and the trust which will really make a difference to cancer research in the future. So I'm now going to change tack for the remaining time of the talk and just give you a flavor for radiotherapy research. And I think this is a relatively unknown area in the cancer field to many, and I hope that this will actually give you some insights into the very powerful nature and benefits associated with radiotherapy. So this slide may surprise you, but in the actual curative treatment of cancer, radiotherapy is used in at least 40% of cases. And that combines with surgery as the two treatment modalities being the powerhouse of the curative treatment of cancer. Now, chemotherapy is increasingly expanded. This slide is a little bit out of date, and these proportions are changing over time. But the main point I wanted to make is how important radiotherapy is, either on its own, combined with chemotherapy, or combined with surgery in the curative treatment of cancer. And part of my mission in the next 15 minutes or so is actually to demystify this. As Arthur C. Clarke said, any sufficiently advanced technology is indistinguishable from magic. So let me try and actually give you some valuable insights into radiotherapy. So it's the use of high energy radiation to treat cancer. X-ray photons interact with the patient, causing ionization of atoms that result in damage to DNA, some of which is not repaired, particularly in the cancer, and that's how the treatment is effective. We carefully design individual treatments to actively and accurately target the tumor. And there's a major focus of how we minimize the damage to normal tissues. And that's something that's evolved over time, which I'm going to show you. And around 50% of all cancer patients will receive radiotherapy as part of their treatment. So as a treatment modality, it's used very broadly in the cancer scene. And as I've said, around 40% of patients cured have received radiotherapy. It's a relatively young specialty. This was the first X-ray picture from Röntgen. That's his wife's hand and her wedding ring. She was appalled at the picture and didn't like it at all, but this really is the iconic picture that signals the start of the discovery of X-rays and its application in the future to a therapy for cancer. The evolution of the technology started with kilovoltage energy radiotherapy in the early 1920s. The first megavoltage X-ray beam was generated using Van de Graaff generators in St. Bartholomew's Hospital, which I'm privileged to train in my radiotherapy career, but not as long ago as 1938. And the first linear accelerator, which is the workhorse and standard approach we use today, began in 1952-53 at the Hammersmith and also in Stanford in the United States. So radiotherapy is used in two settings and is a very valuable and powerful treatment, both in terms of palliation for symptom relief, improving quality of life, and enhancing tumor control. And in the curative setting, either as an adjuvant before or after surgery, as a sole curative treatment, or used in combination with chemotherapy and radiotherapy. So as an adjuvant, one very common example is its use in breast cancer, where it's allowed much more minimal surgery, moving from mastectomy to wide local excision, when the addition of radiotherapy allowed outcomes to be as good as much more major surgery in the form of mastectomy. So breast conserving surgery requires adjuvant radiotherapy in many patients. As a sole curative treatment, for example, in head and neck cancer, in prostate cancer, these are two examples where radiotherapy alone results in long-term cure, results as good as or better than surgery. Concurrent radiotherapy and systemic therapy at the same time of the radiation is used in a number of cancers, head and neck cancer, for example, rectal cancer and anal cancer, which are areas of research interest. And I'll show you one clinical trial as an example of that in a minute. So the linear accelerator generates electrons that are accelerated through a waveguide. They hit a tungsten target, they produce X-rays, and those X-rays are then focused using collimators to shape the radiotherapy beam, and each beam is directed at the tumor. Leeds Cancer Centre, to give you an example of one of the largest in the UK, but there are over 50 radiotherapy centres across the UK, treating 7,000 patients a year, 90,000 radiotherapy treatments, a big multidisciplinary team. And the modern state-of-the-art linear accelerator looks like the picture in the bottom right-hand corner. Here you can see on the side, this is a low-dose CT scanner to take images on the radiotherapy couch before, during, or after treatment. So very briefly, what happens to a patient when they present? They're investigated, they're diagnosed with cancer. They have a number of tests to determine how much their cancer spread, where it is, and then a multidisciplinary team meeting takes place. These happen every week in trusts where radiologists, pathologists, oncologists all meet to actually discuss every newly diagnosed patient, decide the best treatment approach that be used. Patient comes to clinic and then treatment is planned. To plan radiotherapy, you use a CT scan in the treatment position. There is high quality computing and technology that's required for radiotherapy treatment planning, and that's translated into individualized treatment plans for the patient. So this is an example on the left of a highly targeted stereotactic ablative approach, which is very focused and will use a short number of high-dose radiotherapy treatments, in this case for an early-stage lung cancer. On the right, in defining the target, these are lymph node areas in the pelvis that may be involved by cancer from anal or rectal cancer that we would prophylactically treat to prevent cancer developing in patients at high risk of developing spread to those areas. I mentioned the radiotherapy beam is shaped, and on the left-hand side, you can see what's called a multi-leaf collimator, and those heavy tungsten leaves can move interactively to shape the radiotherapy beam, not only before, but also during treatment, and the treatment can arc around the patient whilst delivering the actual fraction or daily treatment of radiotherapy. This multi-leaf collimator I'm showing here was partly developed in partnership with Elekta, and we gave one of the first in-world treatments using this specific multi-leaf collimator, which was an advance on the previous technology for beam shaping. So we have moved historically from radiotherapy beams that were fixed from 3 or 4 different directions to hit the target, to ones where we can actually shape the beam much more accurately using more beams, 5 to 9 beams. And then finally, we've moved to a situation where we can shape the beam by moving the collimators during radiotherapy treatment and also altering the intensity component of the beam. And so we can develop a really focused targeted radiotherapy. And you can see that the turquoise areas have progressively got smaller. And those are the areas of normal tissue receiving lower doses of radiation, which are increasingly minimized. But our mission is to continue to have technological advances to minimize normal tissue toxicity. So how does radiotherapy work? I mentioned it a little bit earlier, that one of its key modes of action is to damage DNA, and particularly double-strand DNA breaks are particularly hard for tumors to repair, and it's exploiting the differential of double-strand breaks in the tumor against the normal tissues, which actually underpins the whole process of radiotherapy treatment and the duration and dose of radiotherapy we use. So radiotherapy will cause indirect and direct damage. Some of that will cause early cell death. Other times, cell death will only take place at the time of the next mitosis, and that's when the DNA damage is expressed. So that accounts for why the response to treatment and actually the shrinkage of a tumor with radiotherapy takes time, because the inherent DNA damage is expressed over a period of time, and the body's ability to repair it and the speed at which it does so will influence the timeline for actually the actual damage to the tumor and its shrinkage. So we have early reacting tissues, which cause some of the acute side effects of radiotherapy involving skin, bowel, digestive tract, and late reacting tissues that the damage can take months or even years to express, particularly in skin, cardiac, blood vessels, for example. So I'm going to finish in the final 5 to 10 minutes just to give you an example of how clinical trials are demonstrating how we use the technology of radiation to improve patient outcomes, and how clinical trials are so important to provide the evidence to change practice in the UK and across the globe. Now, this is a really fascinating study which was performed in prostate cancer. So to set the scene, these are patients who have had newly diagnosed metastatic prostate cancer and are going to be treated with systemic therapy. The clinical trial tested the addition of radiotherapy to standard treatment, of radiotherapy to the primary in the presence of metastatic disease. Now, many people consider radiotherapy as only effective as a local treatment. However, what you can see from this trial result of nearly 820 patients, that the patients who received radiotherapy, shown in blue, actually had improved failure-free and overall survival when radiotherapy to the primary tumor was added to therapy for metastatic prostate cancer. Now, that is a very relatively new finding and is really changing the paradigm and thinking about how valuable radiotherapy is, even in the setting of incurable disease. And although I don't have time to show it today, that is leading to increased usage of combining radiotherapy with DNA damage response inhibitors or immunotherapy to exploit this interaction that radiotherapy may well be having a very positive effect by treating cancer cells who actually may influence metastasis or control the progression of cancer. And if you treat the areas of major burden, such in the primary, you may actually improve the overall survival for the patient. This is the second example of patients who have a small amount of spread of their cancer to up to 4 areas across their body. So that's called oligometastatic disease. Now, again, the conventional thinking would be that if you have cancer spread, it's treatable, but it may not ultimately be curable. What these two trials, and these are phase 2 trials and larger scale trials are underway, show is that the use of short, 1-week, highly targeted high-dose radiotherapy to the up to 4 sites of cancer spread, compared with not using radiotherapy, so patients who are being treated with standard therapies, plus or minus the targeted radiation, there is a strong signal of improved overall survival when radiotherapy is treating the sites of the metastatic disease. Now, we believe that this is most likely to be effective when the actual metastatic burden is relatively low. But again, it has a real strong indication that there may be a future paradigm shift to come, that actually radiotherapy has a very important role to play in patients who have oligometastatic disease. We need more evidence on this and larger scale clinical trials. So I'm going to finish with a final example, which is a rare disease and one I've spent most of my career studying, which is anal cancer. It's a squamous cell cancer arising in the lowest 5 centimeters of the bowel, 1,500 new cases per year, associated with human papillomavirus, presents with bleeding, altered bowel habit, and pain. And I don't have time to show you, but the UK has led the world, and it's been a privilege to be part of and lead clinical trials that have changed the standard of care from what was major surgery and a permanent colostomy to curing anal cancer by using radiotherapy combined with chemotherapy during the radiotherapy treatment. And we're now getting better outcomes than surgery, and we're looking to personalize the treatment further. So this is technology innovation to develop the most effective radiotherapy treatment shaping radiotherapy beams around normal structures by that intensity modulation and shaping of the radiotherapy beams. And you can see how the bladder here is particularly being spared from the radiotherapy. There's no radiation being given here. And the anterior genital structures are being protected from radiotherapy because of this beam shaping. And we're giving higher doses to the tumor, and we can personalize the dose of radiotherapy to the tumor, and therefore we can test that. So Plato is a set of clinical trials that is being led by Leeds Clinical Trial Unit with myself and colleagues across the UK, and testing radiotherapy dose. And two particular trials are testing whether in early stage tumors, we can have really effective treatment with a lower dose of radiotherapy and spare side effects, or for more locally advanced tumors, increase the dose safely with acceptable side effects. So these are three trials called Act 3, Act 4, and Act 5. And the Act 4 is reducing the dose significantly, 4.5 versus 5.5 weeks. We've completed this study. And we've also got another study where we're looking at dose escalation, where we're looking at 2 higher doses of radiotherapy, and we're 80% to our target of actually that particular clinical trial. So the end of this trial, we're hoping to be able to say to patients in the future, if your disease is of a certain size, you may well benefit from having a standard or reduced dose of radiotherapy, depending on the outcome of this trial. Our hope and aim is that we will change practice and that the lower dose will be more effective and improve patients' lives. And in the Act 5 study, that one of the higher doses may be more effective and therefore increase the cure rate of the treatment we're giving. So the overall aim of the study is to actually measure the difference in the 3-year local regional failure rate between the study arms. I mentioned human papillomavirus very, very briefly. HPV expressed with P16. If you are P16 positive, you have a much better outcome. And that's shown in both UK and international data. The question is whether the P16 biomarker is predictive of an alteration of radiotherapy dose. And our trials can test that because we're looking at a randomized comparison of different dose. I'll skip over this slide. We're moving towards a biological model of anal cancer outcomes where both tumor infiltration by lymphocytes, the immune response, and HPV biomarkers may well allow us to be able to approach patients at the start of future treatment, look at their biomarkers and their disease stage, and ultimately say, this is the dose of radiotherapy we need to give to you. We can't do that today, but that's what these trials are designed to show. Finally, these trials are actually looking at circulating biomarkers in the blood. And this is a proof of principle study showing how you can detect HPV mutations in the blood at baseline, and that at 6 and 12 weeks after chemoradiotherapy, complete response occurs. And the initial evidence from this small proof of principle study is circulating biomarkers may be very, very beneficial. So we have a Cancer Research UK biomarker study looking at precisely that. And ultimately, we hope that HPV biomarkers may also ultimately replace scans such as MRI scans to assess the response to treatment. So in conclusion, we have a cancer epidemic. It is a very major global burden, and that's set to rise due to COVID. We need to tackle and understand health inequalities, as I've said. Radiotherapy, I hope I've illustrated, provides a very useful benefit in 50% of patients. And I think the ultimate message is that combining technology and biology is a real key to success to accelerate progress. So thank you very much for the opportunity to share those thoughts with you today. I'd be very happy if we have time to take any questions. Thank you.
Thank you very much, David. I think we can take some questions for the floor. Are there any questions for you? Just chip in if you can, or raise your hand. David, I've got one question for you. Some of the earlier data you presented about those cancers which appear to be difficult to treat and have low survival rates at 5 and 10 years. Could you just elaborate a bit more on the reasons for that?
Yes, I think one of those, Richard, is around but a lot of the time for, say, esophageal and pancreatic cancer, patients have very, very limited on those symptoms. And by the time they develop those symptoms, the cancer, unfortunately, has already had the capacity to spread, particularly at a microscopic level, but even at a macroscopic level. So I think improving early detection and early diagnosis, or ultimately screening, is really, really important. So, for example, pancreatic cancer is a silent cancer for a long time. And by the time someone presents, it may be with jaundice because the cancer has enlarged and blocked the pancreatic bile duct. But at that point, a cancer that has a really wide propensity to spread early may have actually spread very widely. So I think part of that problem, that's the same with esophageal cancer, is we need to find methods of actually either screening or detecting cancer at a much earlier stage.
Okay, thank you. Neil?
Thank you, Richard. Thank you, David. That was a very interesting talk, particularly because I certainly didn't understand the importance of radiotherapy in cancer treatment. So I had a couple of questions, one quite general and the other bit more specific. So the first question is about the increasing burden. What's driving that? Is that demographic? Is that aging populations? And then my specific question was about the DNA damage. Actually, it was interesting that even with that maybe high intensity radiation, it's difficult to get a lot of direct DNA damage. You had 30% or something on your slide. Maybe this already happens with chemotherapy, but would it help to try and increase that that amount of direct double-strand breakage in radiotherapy? And if you could do that with local sensitizers of DNA binders, I don't know if that already occurs, but is that a feasible route, if you like?
So that really, really very insightful questions. I think the global burden is a combination of events, but particularly many cancers are a disease of older age. So our aging population means that as our population grows progressively older and for longer, that is a very major factor. I think the other factors are around lifestyle, multimorbidity, diet, and smoking. Now, we are making significant progress in smoking, but it's a combination of those. I know Amy Downing is going to cover some of the factors that influence cancer, and so that will actually be illustrated in the next talk as well. The DNA damage element, you're absolutely right. Well, there are two aspects here. There is a dose-response relationship. So the higher dose of radiotherapy you can give, you will get a much higher DNA damage effect. But you can only do that safely if you can target very precisely. So one of the real key advantages and advances in radiotherapy has been the technology to be much more targeted and much more focused. And those examples I was giving you about oligometastatic disease is using a radiation dose that's 4 to 6 times higher than the standard dose to very, very targeted small areas, and can now be done safely. And that's probably why we're having a greater effect. Radiosensitizers do not have a great history in research of actually enhancing patient outcomes, but the new generation of DNA damage response inhibitors show real excitement. And actually, we have clinical trials ongoing where we're combining DNA damage response inhibitors with radiation. And I think that's a very exciting future area of research. But also nanoparticles and novel drug therapy mechanisms of getting more chemotherapy into the tumor without systemic side effects is another opportunity.
Okay, great, thank you.
Thank you, Neil. David, you touched on this about earlier again in your presentation. You talked about kind of multimode treatments, and and you get people discussing about things about radiotherapy and surgery, and when you should do one or the other first, and things like that. And Perhaps you could just comment on that. You know, people talk about these
Sure.
things, surgery particularly.
So I think in broad terms, it's been common that a single treatment modality has been effective, but not as effective as it should be, particularly in high risk patients. So rectal cancer is a good example and one that I treat. So very early rectal cancers could be treated effectively with major surgery, but without the need of radiotherapy. So one of the things we've done is through research and clinical trials, we'll refine the fact that there are some patients that really don't need multimodality therapy. But when I was training and when I was becoming a consultant, we had a very major problem with local recurrence with rectal cancer, which is really difficult to treat, highly morbid to patients, and leads to really difficult problems. So we did clinical trials where we tested the addition of radiotherapy to radical surgery and showed we halved or ultimately eliminated local recurrence by adding radiotherapy to surgery. And so clinical trials have refined a selective approach, and that's where the MDT comes in. You look at the extent of the tumor, but if it's more advanced, the clinical trials tell us that actually adding radiotherapy, and particularly before the surgery, can actually improve outcome and abolish local recurrence. Finally, though, that's getting to a stage now that actually we're really realizing there are some patients who actually may be cured with chemoradiotherapy alone. So we have a patient story I could share, but I'll be very brief. We're doing a clinical trial, which is in early stage rectal cancer called Star Trek. And that's comparing radical major surgery, which usually requires a temporary or permanent colostomy, with radiotherapy-based treatment to see if radiotherapy could replace surgery. And we are getting early good results, but it's still in progress. But I think we have examples where patients who actually have been treated have required both radiotherapy, surgery, and a permanent colostomy for the same stage of the disease. And therefore, there is a real opportunity to personalize treatment. So multimodal therapy has undoubtedly improved cancer outcomes, reduced local recurrence, and improved patients' lives. But that still has a risk of over-treatment, which needs further refinement. And I think the clinical trials are incredibly valuable in actually telling us who needs which type of multimodal therapy.
Okay, thank you, David. And finally, if you were to pick one big challenge going forward, what would that challenge be? What do you think a focus of cancer research would be? Obviously, there's going to be a spread and different cancers, but in a more kind of global sense, what do you think the focus should be in terms of a cancer challenge?
So that's a really, really good question. I think there are multiple answers to that. I think if I was thinking entirely broadly, I think ultimately our ability to the holy grail of preventing more cancers could actually have a really dramatic impact. But that's a very difficult challenge. And I think many, many people have focused on that for a long period of time. But the answer ranges from preventing more cancers through to detecting them much earlier and actually more effectively treating them. I think we need to do all three of those. But the biggest impact could be if we actually could stop people from getting cancer altogether. But that's a big ask.
Okay, thank you very much on that insightful last note. I would like to thank Professor David Sebag-Montefiore for his excellent presentation.